Hi everyone, this is Tim, your Block 2 lecture instructor, and this PowerPoint is going to be on diabetes. I want to forewarn you that again, this is going to be a very long session. It's probably roughly 45, 46 slides. You're going to hear and see a lot of redundancy. I find that diabetes is complicated in the sense that there's a lot of information, a lot to learn, but it's simple in the sense that a lot of stuff is really kind of a logical sense. So if you get the basics of diabetes, whether it be type 1 or type 2, which in itself have a lot of the same symptoms and essentially it's kind of the same disease, um, if you get those basics down and figure out how to correct those issues, that's actually fairly simple. The problem you start to run into is the amount of education you have to provide a patient and how much teaching and whether or not they understand. And like I said, really the key is really just reiterating things over and over and over, just to the point where they've heard it enough that it finally kind of sinks in. So again, like, as we go through the slides, if you feel that you've heard this before, why does he keep saying that? It's really because a lot of stuff is rather redundant, but it's the context of what's really going on. So you'll see. Now, anyway, sit back and relax and listen to my wonderful, charming voice. All right, so for type 1 diabetes mellitus, which is also, as you see this PowerPoint, you'll see a lot of abbreviations because it's just easier, especially for nursing. So for diabetes mellitus, it's the initials DM. So it's an autoimmune disease, usually diagnosed in children and young adults. It's beta cells that are destroyed, and there's no insulin production. So hormone needed to convert sugars, starches, and other foods into energy. So again, this is for patients who are very young, usually 15, 16, 17 years of age. In fact, they could really be small children. I have a friend that her son was diagnosed at the age of, I think, 5 or 6. And they're doing okay, but it took a lot of not only teaching the parents and understanding what the disease is, but how do you teach a child that's 5 or 6 years old to check their sugar 3 times a day and before they go to bed and understand that their sugar is high or even what sugar is and be able to poke themselves with syringes and give themselves insulin and try to get through that. So anyways, kind of keep that in mind. The type 1 diabetes is usually for younger adults and possibly small children. So for type 2 diabetes, it is a progressive disorder. It's a combination of insulin resistance and a decreased secretion of insulin. It's reduced ability of cells to respond to insulin. So for this person, it's usually an older adult. They have the ability to produce some insulin, but not enough for what their body size or what they're consuming. And they also may just have the inability to they produce the insulin, but it just doesn't react the way it should. And again, this is usually older adults. Type 2 diabetes, it develops with obesity and physical inactivity in a genetically susceptible person. So you could, watch your weight and exercise and be very healthy, but if genetically you're susceptible, you may eventually end up having type 2 diabetes. But it tends to affect more people that are obese, that aren't very healthy and aren't very active, and they're more predisposed to it. It's often accompanied by hyperlipidemia, hypertension, and increased clot formation. And we'll talk about those things in a little bit. So features of type 2 diabetes, it's middle-aged adults, abdominal obesity, inactive, high-risk ethnic populations, which when I found in your book, I read it and I thought, well, between the African Americans, the Hispanics, the American Indians, the Asians, and the Pacific Islanders, there's really not a lot left except for Caucasians. So, but I think that's kind of a growing population too. So essentially everyone at this point is really high risk, just based on lack of diet and exercise and just being sedentary. So for type 2 diabetes, teach the patient about lifestyle changes, have them lose weight, learn how to diet, and obviously exercise. I found that in my nursing experience and even in personal experience with friends that if a patient or someone gets on these meds for diabetes and they lose their weight and they start to eat right and exercise and become healthier, that allows them to possibly get off the medication. So, so kind of, it's more of an incentive. Yes, you're a diabetic, but if you start to change your life for the better, you may be able to actually get off the medications, which essentially is what every patient wants. So features of type 2 diabetes, it's a history of vascular disease, which is hypertension, hyperlipidemia. The HDL is less than 40 milligrams per deciliter in men and 50 milligrams per deciliter in women. Triglycerides are 50 milligrams per deciliter or higher. Any of these health problems increase the rate of atherosclerosis. Atherosclerosis leads to stroke and coronary artery disease. So if you have a patient who you're able to teach how to control their blood pressure, how to lower their cholesterol and lower their triglycerides, they're less likely to get atherosclerosis, which then prevents them having strokes and coronary artery disease. One thing I like to mention that, and I'll do this throughout the PowerPoint, is things that come, that I think about as I go. Think about diabetics if they have high blood sugar, think of it as being almost like syrup. The thicker the blood, the less it's able to circulate correctly. And that will definitely fit into the latter part of this PowerPoint. But my point for right now is that if things are thicker and running slower, then things tend to not perfuse well. And that's where these things come into effect. If your blood's already thick and you have hypertension and you're trying to pump that thick blood throughout your system, but you also have high cholesterol, now you're pumping thick blood and a slightly thicker blood because of the lipids that are in it, and then you now have higher sugars, so it's even making things even worse. So you're just adding more and more things onto something that's already a problem. So that's the biggest thing, is trying to prevent that. So for an assessment, you're going to look at the patient and figure out as far as age. Again, type 2 diabetes affects more older adults, so that kind of puts them into play. Look at the weight of children at birth. Women who have children who weigh more tend to develop type 2 diabetes later on in life. The weight and weight changes. Some patients will actually go up and down severely as they're in the beginning stages of diabetes. You're going to look at major and minor infections. You're going to look at vaginal yeast infections, skin injuries that become infected and they take longer to heal. Because again, if your blood is thick and you're not actually controlling it, it tends to, those small little cuts and the paper cuts and the little, blisters you have on your feet. For us, they heal fairly quickly, but for people who have thick blood that's not circulating well, that takes much longer, and eventually that becomes a bigger issue and becomes more infected. Patients who have a possibility of diabetes also have vision changes. The capillaries in the eyes are very thin and very microscopic, and if you have thick blood that's not really able to circulate real well, that will also cause changes in their vision. And in the same concept, it also will change their sense of touch. They'll end up starting to have numbness and tingling and actually have pain. So for labs, you're going to look at normal blood glucose, which is 100. So for all of us who are sitting here listening to me that don't have diabetes, we're probably sitting here around the 100 range. Right now I'm drinking coffee with tons of sugar in it, and my pancreas is actually doing what it's supposed to. The more sugar I consume, the more it pumps out insulin, and it just creates that homeostasis balance and levels out my blood sugars. People who don't have a pancreas that either doesn't work or doesn't work well, they don't have that ability. So you drink that cup of coffee with half a pound of sugar in it, and it's really just floating around. So definitely check their labs. A fasting glucose test is higher than 126 milligrams per deciliter and indicate impaired fasting glucose. So I woke up this morning, I had nothing to eat all throughout the night, and that's your fasting. I wake up, I check my blood sugar, and if it's higher than 126, then we know that there's an issue. They'll also do a oral glucose test where they actually give you sugar and then actually test your blood to find out if your pancreas is taking care of that. The patient should be tested more than once to be accurate in diagnosis. So if I woke up this morning, had nothing to eat, nothing to drink, no sugar, and I'm, let's say 150, 175, 100, 90, and 200, it may show that I possibly have diabetes or predisposed to diabetes, but let's do it more often than once, because let's just say that 150 was slightly a miscalculation, or something was actually throwing the test off. You don't automatically want to assume that they have diabetes. Put them on medication and find out that it's really now causing other issues because there was nothing there to fix in the first place. So other labs, you're going to look at the HbA1c. This is how much glucose is attached to the hemoglobin molecule. Normal is 4 to 6%, and more than 8% is considered poor diabetic control. So, and this is usually a test over a 6-week period. So, let's say you go to the doctor, he does a fasting blood glucose, he finds out that you're 150, 160. He decides to do it again. He finds out, wow, you're still, pretty much higher than the 126. They may do an HbA1c, find out over the last 6 weeks, is there a trend? And if you are higher than the 6%, then you are considered a diabetic based on the amount of glucose that's been attached to it. If you fit between the 4 and the 6, which is probably what we are right now, you should be fine. All right, so other tests, you have a urine test, which will test for ketones in the urine. Ketones in the urine indicate blood sugar of 300 or higher. Once your blood is so thick and so full of sugar that it actually starts to spill into the bloodstream, and again, that has to hit a certain point, and usually it's about 300. I know that we are not asking you to memorize or understand, or we know that the diabetic ketoacidosis is part of this module, but I do mention a lot just because I want you to be aware of it. So definitely read it in the book. Like I said, you don't have to memorize it, but just kind of understand, because one symptom may lead to one thing, but a symptom that gets worse will lead to another, and that's where diabetes goes into effect, or the problems you see. So. Other labs, you'll do a urine albumin, because you'll find that there's actually protein in the urine. They'll have urine glucose. It's like testing your blood, but it's in urine. I have a friend who is from England, and he's a type 2 diabetic, and every morning he pees on a stick, and he'll tell them whether or not his sugar is high based on that litmus test. So I'm not quite sure exactly how accurate it is, but he's been doing it for about 10 years, and he's not dead, so must be doing pretty well. All right, so other symptoms of diabetes. You'll urinate often, you'll feel thirsty, you'll feel hungry, extreme fatigue, you have the blurry vision, cuts and bruises that do not heal quickly, and you'll also have weight loss. So again, like I said, you're going to start hearing the same things over and over, but it is a redundancy in the sense that the symptoms are always there, and it's just a matter of how you're going to take care of it. All right, so you have diabetes. Now what? It's all about the education and all about the training, and that's what the rest of this is going to be about. So for hyperglycemia, blood sugar, glucose, or blood sugar, BG or BS, is the amount of blood or the amount of sugar that's in your blood. With too much too much sugar in your blood, it causes type 1 and type 2 diabetes. It could be you ate more than you planned, meaning that you exercise less than planned, stress from illness such as cold or flu, or stress, just basic life stresses, or the Dawn phenomenon, and we'll go over that towards the end of the PowerPoint. But with hyperglycemia, it means that you have too much sugar in your blood, and it could be because of these things. So, and this is actually someone who has actually been diagnosed. So symptoms of hyperglycemia, you have a high blood glucose, so you're going to check your blood sugar often, high levels of sugar in the urine, frequent urination, increased thirst, feeling hungry, extreme fatigue, and blurry vision. Again, you've heard this before, but these are the typical symptoms of someone who has too much sugar in their blood, hyperglycemia. So if it's untreated, the blood, again, will become very thick. You'll have too much sugar in your blood, and you'll end up getting ketoacidosis. And this is from broken down fat and increased urination. You will have shortness of breath. Your breath smells fruity. You'll have some nausea and vomiting because your body is trying to create the homeostasis. You pee too much and you have nausea and you have vomiting and you have diarrhea because your body's trying to get rid of something and it just can't do it. You also have a symptom of dry mouth. So this can all be prevented if the patient actually checks their blood sugar all the time. You want to treat it before it actually gets worse. And other things you can actually do is diet and exercise. And it'll make sense in a second. So with diet, you want, I know your book actually says a little bit different as far as the amount of grams or carbs a person can actually have per meal. But typically, what I have found in the hospital, whether it be Scottsdale or Banner, it's usually 45 to 60 grams of carbs per meal. The foods with carbs are grains and grain-based foods, such as bread, cereal, pasta, and crackers. Starchy vegetables, which are potatoes, peas, and corns. They also have fruit juices, milk and yogurt, dried beans, sweets and snacks, low-calorie sweeteners, sugar, alcohols, and even fiber has carbs in it. So the reason I brought this up is I want you to realize that for those of you who are not diabetics, we eat cake for breakfast, or a bowl of ice cream before we go to bed, or we go out to meals and we just eat because we can. We may watch what we eat, we may try to diet and exercise, we may just try to live a better, healthier lifestyle, but with patients who are diabetics, everything they eat has to really be looked at, because if they're only allowed to have 45 to 60 grams of carbs per meal, then simple things like pasta. I mean, I grew up in an Italian home where pasta was like a staple food every night. But as a diabetic, you have to kind of watch, well, I ate that cup of pasta, I may just have hit all my grams and now you can't have anything left. So, and this is a pretty big list, so it really cuts down on what you can consume, and especially when trying to watch your blood sugars. So definitely keep that in mind. So for exercise, balanced food consumed with insulin doses and activity for type 1 diabetic. You have balanced food consumed with medication and activity for type 2 diabetics. Exercise lowers blood sugar. So if let's say you eat a piece of cake and you decide to actually go to the gym, by you working out, you actually burn off that sugar. So you don't necessarily need the insulin. Now, it doesn't make you not a diabetic. It just means that your body is actually doing something different with that sugar that's in your blood. So exercise will actually help lower your blood sugar. It prevents lows. So know your blood sugar before your activity. Because if you actually take insulin, let's say you had some breakfast this morning, and let's say you had some cereal, you had your 45 to 60 grams of carbs, and you gave yourself the insulin to make sure that you stayed within a normal range, which is that 100 grams. If you work out, you have insulin in you that's combating the sugar that you consume for breakfast. If that insulin brings you back down to 100 from eating breakfast, but then you actually work out, then you're going to burn off more sugar, which may lower you down to, let's say, 80 or 75 or 60. That's not a normal range. Now you do not have enough sugar in your blood. So test before and after exercise. So if your blood glucose is less than 100, then you want to eat a snack. It's all a matter of trying to balance it around that 100. So carry juices, glucose tabs. This will give you quick sugar. So if you do drop down to 75 and you do the glucose tabs, which is basically a sugar tablet, or some juices, then it will actually bring you back to the 100. It's okay if it brings you to the 126 or the 150 to the 200. At least you're getting yourself above the normal range, and then you can kind of slowly start to balance yourself back out. Vigorous exercise causes stress, so stress causes blood glucose to rise. All right, so why is your blood glucose rising? So this could be too much food with more carbs, not active enough, not enough insulin or oral medication, the side effects from a medication such as steroids, or illness, which causes stress, which also causes your blood sugar to rise. Pain can also make your blood sugar rise based on stress, menstrual periods, and dehydration. Because at this point, with dehydration, you actually don't have enough fluid to dilute the amount of sugar that's actually in your blood, so it causes more. So why is your blood glucose falling? So it could be because of not enough food or carbs. It could be from alcohol, too much insulin or oral medication, or too much exercise, as we spoke about that before. So how to lower your blood glucose with oral medication for type 2 diabetics. It could be a combination of oral medication and insulin if orals aren't enough. So for type 2 diabetics, they could take a pill, such as metformin or glipizide, and it'll actually help lower the blood sugar because they do still produce insulin, but just not enough. And the oral medication is to help, with that to make them work together. If that's not enough, sometimes your patients who are on oral medications will also have a slight insulin, whether it be 1 unit or 2 units or something, just enough to make it a little bit more efficient. With insulin for type 1 diabetics or type 2 diabetics, there's insulin therapy. So we have rapid acting, we have short acting, intermediate acting, and long acting. So on page 1431, box 67-9, this actually has a list of all those insulins. Now, I know you're going to groan, but I need you to memorize all those because when you get into the hospital, or if you're working out in the field, or if you're doing visiting, nursing care, you need to be able to understand what these different insulins are, how they work, and the time frame that they actually work, because that's going to help you teach your patient when to eat, when not to eat, when sugars may be too low or sugars may be too high. So it's a lot to memorize, but you need to know them. So you also need to know your injection sites, which I know you guys learned in block 1. And I also want you to look at page 1435, box 67-5, which is the administration of the cloudy and the clear insulins. So when I was in nursing school, that was one of our questions was, how are you going to draw up the regular insulin and the intermediate insulin, because one's cloudy, one's clear. So there's a way to actually do that, so you don't just mess up the bottles in a certain way. All right, so for patient teaching, teach the patient the insulin types, injection techniques, how they're going to respond to these different insulin types, the absorption and onset and the duration of the insulin regimens that duplicate the normal. So if you and I eat the cake and we don't have diabetes, our body's going to offset that and actually produce enough insulin to correct the blood glucose level. You're trying to do that same thing with diabetics. So you're trying to be as normal and duplicate that process as close as possible. So insulin release pattern and sticking to schedules. That's the hardest thing. We're all busy and we don't always eat breakfast, lunch, and dinner at 8, noon, and 5. So if you could, then your insulin would work perfectly, because you would eat, do your insulin, eat 4 hours later, do your insulin, eat 4 hours later, do your insulin. But that's not real life. So you try to come up with some sort of schedule, and you try to stick to it as close as possible with realistic expectations. I found that nurses who actually have patients that are diabetics, you try to go in there with the knowledge that you have, based on being book smart, but you're trying to teach it to somebody in a way that is unrealistic, and that it just shuts your patients off. They don't listen. So try to be able to be realistic, try to understand where they're coming from and what they're capable of doing, and you'll find that they'll actually listen to you a little bit better, and it makes them feel like you understand, and that you're just not robotically spewing information to them and just kind of walking out. So I think the more you can relate to them and understand where they're coming from, the more you'll get from them. All right, so side effects of insulin. So if you have too much insulin, or if you don't have enough sugar in your blood, you will get hypoglycemia. So hypoglycemia is a low blood glucose that is below 70 milligrams per deciliter. The symptoms of this are going to be shakiness, nervousness or anxiety, sweating and chills, you have clamminess, irritability or impatient, you have confusion or delirium, rapid, fast heart rate, lightheadedness and dizziness, you have hunger and nausea, you have sleepiness, blurred vision, headaches, weakness and fatigue, anger and sadness, lack of coordination, worst case scenario, seizures and unconsciousness. I know it's a long list, but just think of it this way. If you need sugar for energy and you don't have enough sugar in your blood, then things really slow down. So with that, you start to have the reactions from it. And I think the biggest thing that I've seen in the field is more of the sweating and the chills, the clamminess, the confusion. The delirium is not as severe as it sounds. It's more of a forgetfulness, or it's almost like forgetting your keys. You just can't seem to find them. You're not confused. You're not delirious. It's that moment of forgetfulness. The lightheadedness and dizziness I have seen. Sleepiness is definitely what I've seen, especially with dialysis patients. The blurred vision and the headaches, that's something I've seen before. Weakness and fatigue, like I said, everything's slowing down. And I'd probably say the lack of coordination. So these are things I definitely seen with patients who have not enough sugar in their blood. So the treatment for hypoglycemia, you're going to consume 15 to 20 grams of carbs or glucose. So let's go back to the example of working out. Woke up this morning, I ate my cereal, I took my insulin to make sure that I had enough insulin to offset the amount of sugar that I ate. I went and worked out, and all of a sudden I checked my blood sugar because I'm having the symptoms of hypoglycemia, which let's say I'm clamminess and got that rapid heartbeat. I'm starting to feel really tired. There's a difference between I worked out and I'm tired and I really feel tired. So let's say I had those symptoms and I decide to check my blood sugar and I find out that I'm at 65. I'm going to, whether I grab my glucose tabs or my juice, and I'm actually going to drink it or consume it. And then 15 minutes later, I'm going to recheck my blood sugar. If it hasn't come up, then I will actually repeat the blood sugar and do it again. And I'll go ahead and do the glucose tablets and the juice. As long as you're alert and oriented and sitting up, you should be able to consume the carbs until your blood sugar goes up. And now, like I said, if let's say a half hour, 45 minutes, or an hour later, all of a sudden you went from 65 to 200, that's fine because you can control that. But if you keep falling and you're not doing anything about it, eventually you're going to get so low that you will have seizures and you'll be unconscious and possibly die. So the idea is to actually start low and go slow. So every 15 minutes, keep rechecking until you actually hit that 100 mark. Use your juices, use your glucose tabs, and get you up as high as you can get. So if it returns to normal, then plan your next meal, because now you have to understand that you went to the gym, you worked out, your blood sugar was 65, you got it back to 100, and now you're hungry. So you go to, I don't know, let's say McDonald's, and you actually eat a small meal, try to watch your carbs, but you still have insulin. You still have the effects from working out working against you. So plan your next meal so that way you're not going to go extremely high, but you also make sure you eat enough to make sure that you're not extremely low. So again, diabetes is really just a balance above and below that 100 and trying to keep yourself within that normal range as close as you possibly can. So what are 15 grams of simple carbs? They could be the glucose tabs, as I mentioned before. They actually have little tubes that have sugar gel in them. You can use that. 2 tablespoons of raisins, 4 ounces of juice or regular pop. I had to laugh when I made this because I'm from Ohio. We call soda pop. But yeah, definitely anything with sugar in it will actually help. 1 tablespoon of sugar or honey, 8 ounces of non-fat or 1% milk, hard candies or gumdrops. I have the friends that I have that are diabetics, they tend to use the hard candies because it's just quicker and simpler. If you are working at the gym, you find that the person next to you who's on the treadmill who is diabetic, and let's say they feel lightheaded, dizziness, they stop the machine, they step off of it, and next thing you know, they fall down, and they're not necessarily unconscious, but they're not feeling very well. The first reaction is to grab something that has a lot of sugar in it, and you can actually pour, sugar packets in their mouth, as long as they don't choke. But the idea is that putting it sublingually will actually get that sugar into their bloodstream very quickly, and that's how you react to somebody who is having too low of blood sugar. Or in the hospital, you can actually give glucagon. It's a hormone that stimulates the liver to release stored glucose. So that way you're going to go from hypoglycemia to that target 100 range. Glucagon actually comes in a syringe, and you actually put it through the IV, and you basically put it, you just do it IV intravenously. So. All right, so let's see here. Blood glucose control in hospitalized patients. So hyperglycemia, especially stress hyperglycemia, could be caused from illness. Could be caused from decreased physical activity, because your patients are typically laying in bed all day long and not moving too much, so they're not able to burn off any sugar. Another reason for hyperglycemia could be withholding of anti-diabetic drugs. We all know that metformin is held at least 48 hours prior to some sort of CT scan with contrast, and you actually have to hold it 24 hours afterwards because the contrast is already hurting their kidneys, and the metformin makes that even worse. So definitely understand that concept. If your patient comes in the hospital, let's say they're hospitalized and they are taking metformin, the hospitalist or the doctor will usually automatically take them off of it, and it doesn't matter if they're having a CT scan or not. They just don't reorder it, and the patient doesn't get it at all while they're in the hospital, with the intent that if something happens, they need a CT, they don't have to worry about the kidneys. With that said, what they will do is they will actually put them on insulin instead, and check their blood sugars, breakfast, lunch, and dinner, just to make sure that they aren't going hyperglycemic. So drugs that can cause hyperglycemia are steroids, which is like prednisone, salmeterol, medication, especially for COPD patients that you need the steroids to help as an anti-inflammatory. Those will cause your blood sugars to go up. TPN and PPN, those are maintenance fluids that you give somebody who is not able to actually eat or drink. It's almost like a normal saline bag, but it's got all the vitamins, minerals, and everything that your body possibly needs. It's just in a big, huge bag. But that has a lot of sugar in it, so it will also cause hyperglycemia. And tube feedings also have a lot of sugar. So remember, with tube feedings, what goes in comes out. So and like I said, that's really kind of a sugar-based substance. So you have to watch with that. So blood glucose control in hospitalized patients. So in order to control it, you want to actually control the infection rate. Blood glucose can be higher due to infection. So you come in with a cut on your big toe that it's going to you already know it's going to take a longer time to heal. The longer time it takes to heal, the more apt they're going to possibly get an infection, and that infection will cause your blood glucose to rise. So it's kind of a, patient has a greater chance of developing an infection due to diabetes, and that infection causes your diabetes, your blood sugar to go up. So this can be better controlled with IV insulin. Now I don't think we actually want you to know a lot about IV insulin, but it's still a concept. You may see this in clinicals. Someone comes in with a blood sugar that is 300, and we already know that that's at least ketoacidosis. But in order to lower that, if you actually put them on an insulin drip, the nurse can actually control how much insulin they get in order to lower their blood sugar. And if it gets too low, then you kind of titrate that to slow down a little bit so the blood sugar comes back up. So if you can control, it's almost like controlling someone's blood sugar around that 100 target just with IV insulin drip. So you can control it as far as how fast it goes or how slow it goes to be able to still hit that 100 milligram target. Hospitalized patients may also develop hypoglycemia, and this could be due to inappropriate insulin type. So you have a patient comes in, they're 80 years old, they're not quite exactly sure what insulin that they're on, because again, there is 4 or 5 different ones. If they can't remember, it's hard for us to actually know that. So we put them on what we think may be the best one for that time period. And if it's not necessarily appropriate, it could either work too much and give them hypoglycemia, or maybe it's not enough and gives them hyperglycemia. Timing of meds and insulin administration. At the hospital, we used to actually do it. We check their blood sugar, breakfast, lunch, and dinner, 8, 5, and or 8, noon, and 5, and we would, if they were high, we just give them insulin. Now, we know based on them eating and not eating, obviously you have to use your nursing judgment. But if you test their blood sugar, breakfast, lunch, and dinner, and you give them insulin to actually control what is happening at that moment, and they don't eat for a couple hours later, then you now have insulin in you to lower it back to the target of 100, but then they didn't eat, so now the insulin may actually work too much, and now you've fallen below the 100, and you can be in the 70 range. We also use something called the sliding scale. With Scottsdale, we use a 1 unit for every 50 over 100. So if your patient is, let's say, a blood sugar of 150, you're actually going to give them 1 unit of insulin to get them back to that 100 target. I think with Banner, I think it might be, if the patient is 150 to 200, you give a certain amount of units. If they're 200 to 250, it's a certain amount of units. So keep in mind, there's actually a sliding scale based on the amount of insulin you give is determined based on their blood sugar. And like I said, the target is about 100. You can also have hypoglycemia due to being NPO or unable to swallow. Patients who are unable to swallow or haven't had a swallow study, they're really not getting anything to eat. So you give them maintenance fluids to keep them hydrated, but that dilutes their blood. So if it dilutes it, and they're not actually if they're not actually consuming enough sugar, it will cause the blood sugars to be low. I've said this in block 1 before, patients who are actually NPO, your body will break down fat in order to keep energy going, and that's actually going to release sugar. So your body breaks down the fat, it releases sugar for energy. Whatever it doesn't use is now just swimming around in your bloodstream. So you could possibly have hyperglycemia because of the amount of sugar that's actually being put into the bloodstream based on the breakdown of fat. So I hate to sound as if it's not, I don't want to confuse you, but it's just, think in mind that your patient that's NPO may be hypoglycemic because they're not consuming the sugar, but remember they might be hyperglycemic because of the fat breakdown. So. All right, so enhancing surgical recovery. So you will see in the hospital patients who have surgeries, whether it be gallbladder removal or their appendix removed, open heart surgery. Let's say that they had to have a big toe amputated. Any surgical process will cause your patient's blood sugar to rise. So you have a patient who is diabetic in need of surgery. Your plan and expected outcome is to promote good wound healing, create an absence of infection, make sure that their blood sugar levels are within normal range, and discharge readiness. So this includes educating the patient on their procedure and their diabetes. I mentioned this before. It's hard to actually teach someone something as they're tapping their foot at the doorway waiting to be discharged. And as soon as you hand them paperwork and you try to sit down with them and actually explain to them what their discharge paperwork is and what their instructions are, they really don't care. They're waiting for the ride, they're already dressed, they're ready to go, and they're walking out the door, and you're trying to give them information as you're taking them to the elevator. They're not listening to anything you're actually saying. So you have to keep that in mind. So for good wound healing, you want to keep things as clean as possible because, again, patients who are diabetic are slow to heal. Slow to heal is more of a risk of infection, but if you keep things as clean as possible, that risk goes down, and that creates the absence of infection. Keeping the blood sugar within normal range will help with the lack of infection and also promote the wound healing. And as far as discharge readiness, again, teach your patients from day one. Patient gets admitted and just start teaching them as far as the procedure, what they're having done, and include their diabetes in that because they may understand what diabetes is to a certain degree, but they may not realize that the actual procedure is going to cause their blood sugars to go up or possibly cause their incisions not to heal and their infection rate goes up. And they don't understand these things, so you have to be able to combine the two so they can understand. So for preoperative care, stop the metformin 48 hours prior to surgery. Put on intermittent insulin because you do have to at least give them something. And you want to keep the blood glucose levels below 200. Now, the reason why this says 200 and not 100 is because with stress comes higher blood sugar levels. Sometimes you have to be able to look at the patient and go, we're never going to get you back to 100, but we are going to try to get you now close to 200 because you have a lot going on, whether it be incision, infection, stress, pain, all those things drive your blood sugar to go sky high. So instead of trying to be an unrealistic 100, let's try to at least shoot for a realistic 200. Higher level promotes infection and slow wound healing. We've talked about that before. So intraoperative and postoperative care. So intraoperative care, you're going to do an IV insulin, glucose, and you're also going to watch their glucose and potassium. So for intraoperative care, if your patient does go up and becomes hyperglycemic, and they're actually, let's say, a target of 200 or 250, then the IV insulin drip allows you to actually control it as much as possible. So it allows you to titrate and decrease the amount of insulin that's going into them based on a insulin drip. Now, you want to give them glucose so they become hypoglycemic to make sure that they go back up to that 100 or so. You can turn the IV insulin drip down. But as we mentioned in the other modules, that the more insulin you give someone, the more it actually drives the potassium into the cell, and that doesn't have enough potassium in the vascular system. So you have to watch how much potassium is in their bloodstream to make sure that you aren't becoming hypokalemic. So this is to keep blood sugar 140 to 180 because that's a realistic target for surgery patients, and this reduces wound infection. So post-operative care, you still have the IV insulin drip. Could be used, it could not. I've had patients that are diabetic that aren't coming to me with an insulin drip. But again, if they're in that 200, 250, 300 mark, then they tend to put them on it because it's easier to titrate. Keep blood glucose levels between 140 and 180 for critically ill patients, but you want to keep them around 100 to 110 for med-surg patients. So I know it seems to start getting kind of confused with a target of 100, but then now you want a target of 100, and now you want a target of 140 to 180. So keep in mind that the normal person that may have diabetes, your target is 100. That's for everyone. We're trying to get them to 100 to be normal. But you want to try to keep them as normal as possible. So if someone comes in and they're very sick and they're at a level of 300, then your realistic target is around 200. With postoperative care for critically ill patients on IV insulin drip, you're able to titrate them a little bit better between the 140 and the 180. If they come to you on a med-surg floor and they're hanging out around 120s, 140s, then your realistic goal is going to be the 110 to possibly maybe 100. So again, keep in mind baseline and realistic goals and try to get them as close to 100 as possible. Definitely watch for acute renal failure and hypokalemia. So we talked about that before. Definitely watch those potassium labs. All right, so for post-operative diet, always assess for bowel sounds after a patient has surgery. We talked about that in block 1. Patient has surgery, they come back, anesthetic slows everything down. Their bowel sounds are either hypoactive or not active at all. So as the bowels become more active, they start to wake up, anesthetic wears off, the patient can actually start to consume solids and liquids. Now, the doctor will tell you, just had surgery, make them NPO until you start to hear the bowel sounds. If you do, they want to put them on an advanced as tolerated diet. This allows you to start with a clear liquid diet and then kind of go to maybe a full liquid, which is more like soups. You can do a soft diet, which is like more mashed potatoes, and then you can actually do a regular diet, which really can be anything. I tell my patients all the time, just had surgery, I'm not going from you being on a clear liquid diet to a steak, because your body still has to be able to process that and break it down. So if your bowel sounds are actually becoming active, yeah, they can actually eat what they want and they'll still process, but kind of gradually, slowly build them up to the regular diet. But with that said, clear liquids and full liquids should actually have a total of 200 grams of carbs for an entire day, and you don't want them to be sugar-free. And the reason why is that sometimes your post-operative patients will start to become hypoglycemic while their bowel sounds are kind of going back to normal. With tube feedings, you actually want to do 50% of carbs because, again, patients who have abdominal surgeries or have other surgeries, if they were on tube feedings before, they're coming back to you on tube feedings. But again, they're coming back to you with a hypoglycemic issue. So you want to kind of give them more carbs and kind of keep that blood sugar level higher. Advance the patient's diet is tolerated as fast as possible, but again, don't go from clear liquids to a steak. Really go from like clear liquids to a full liquid to a mechanical soft as soon as possible so that we can kind of get them back on track. Patients on TPN have less of a worry due to insulin added to the fluids. So I told you that TPN is like maintenance fluids with all the vitamins, minerals in it. It has a lot of sugar in it and stuff, but they're also able to actually add insulin to that TPN in order for you to still get it. So it's almost like a combination of an insulin drip and a bag of normal saline. It's a combination of the both, but it has everything they need. And this is for your typical diabetic patients. So the blood sugar kind of is doing its job for you, but you will check them breakfast, lunch, and dinner just to make sure that the insulin that's in the TPN is actually working the way it's supposed to. Now, I also will add this little disclaimer. If you have a patient who is not diabetic but is not able to eat for, let's say, abdominal surgery, and it's going to take them a couple weeks for that abdominal surgery to either heal or the bowel sounds to actually wake up, so they're not able to consume any food for a couple weeks, they will actually put them on TPN so they can get their vitamins and minerals. But even though they're not diabetic, you still will check their blood sugar just to make sure that the sugar that's in the bag isn't too much for them. So I hope that makes a little bit of sense, but I just want you to make that be aware of it, because when I came out of nursing school, I was testing a patient breakfast, lunch, and dinner on TPN, and I was like, well, are you diabetic? They're like, no, I'm not. But it's because of the amount of sugar that's in that TPN. You want to make sure that it's not giving you too much. All right, so neuropathy. Peripheral neuropathy is a result of damage to your peripheral nerves, often causes weakness, numbness, and pain, and usually in your hands and feet. It can also affect other areas of your body. Sensory nerves that receive sensation from the skin, such as temperature, pain, vibration, and touch. So they're motor nerves that control your muscles to move. All these things may actually be damaged due to diabetes, and that's called neuropathy. So the numbness, tingling, and pain, that's very real. You'll go to assess a patient, you'll start your head to toe assessment, you'll listen to heart and lungs and bowel sounds, and you'll check their pulses, and then all of a sudden you grab their legs to kind of find out if there's any type of edema, and they literally jump out of bed because you just the touch itself, the squeezing, even if you don't do it very hard, that's very painful, and it's like sending pins and needles up and down your legs. So for your patients that are diabetics, that you're going to assess, ask them how their legs feel. So when you do try to assess them, at least they're not jumping out of bed, you're not causing a lot of pain. But neuropathy is a very big thing with diabetics, and I think every friend and every patient I've ever had that is a diabetic for long term, they definitely have neuropathy pain, and it's very painful. So patient teaching. The number one intervention is prevention of injury, because with peripheral neuropathy or any neuropathy comes the numbness, the tingling, and the pain. They have a better chance of actually having some sort of injury, whether it be from falling, whether it be from burns or stepping on something that's very sharp. They don't feel a lot of this stuff, so you have to definitely teach your patient and keep in mind that you have to be able to prevent as much prevent as much as you possibly can so your patient doesn't actually get hurt. So other teachings for patients who have diabetic neuropathy is going to be follow foot care practices, have them inspect their feet daily, have them see a podiatrist as regularly as possible. Make sure that they clip their, have either they learn how to clip their toenails perfectly or have someone trained to do it, because it just takes one little nick of somewhere on your foot, and that's going to cause major issues with infection, slow wound healing. It's going to cause a lot of problems. Wear properly fitting shoes, which is a big deal. Avoid walking in your bare feet because you'll step on stuff and you don't know it, don't feel it. See a podiatrist very often. As a side note, diabetic patients with neuropathy who develop foot ulcers tend to lose their toes, feet, and lower extremities. This is not all patients, but my experience has been that patients who have diabetes, even if it's controlled diabetes, again, they have thicker blood and it's hard for it to reach to the extremities. That allows wounds to take a very long time to heal, a very higher risk for actual infection, and it just never they just never get over it. And at some point, doctors realize that, you know what, it's just better just to cut off that toe, and suture it up, and try to start from scratch. If you have a nick on your foot that's not healing, what's the difference between that or cutting your toe off, suturing it up, and trying to get that to heal? It's the same process. It's going to take the same amount of time, but at least you're actually trying to start fresh and actually get something to heal, rather than letting the toe become necrotic or infected, and then it just causes other issues. But I find that patients who are just in horrible, condition as far as diabetes and infection and wounds, they start with the toes, and then it turns into a foot, and then they literally do below the knee amputations just because they just try to start over and over. But your patient just didn't come in and the doctor says, okay, well, this is probably not going to heal, we're going to cut it off. They really have been in the hospital for a long period of time, and they've tried everything they could, and it just didn't work, and that's when they start doing the amputations. But you have to teach your patient that. I mean, at some point, your patients will come to the realization and accept the fact that they're going to lose toes and feet and extremities. But how do you explain that to somebody? You have to be able to teach them and try to get them to understand that this is a process of the diabetes. It's very hard to do, but you got to do it. Also, I want you to look at page 1447, box 67-7 and 67-8. All right, so for wound care, moist wound environment, so you're going to do more wet to dry dressings, and I think you guys had learned that in block 1 with the abdominal incision. It's the same concept, you're actually just moving it to different parts of the body. So let's just say it's an ulcer on the ball of their foot. It's healing properly, it's getting deeper. What you'll actually do is you'll use normal saline, or whatever the doctor prescribes. There's a million different solutions out there that doctors don't like, that work, don't work. There's just be aware that there's a lot of stuff out there that that's solutions that you can use 4x4s to actually soak. You actually pack the wound, and then you actually put a dry 4x4 or something over top of that, and then you actually wrap the foot. But you want a moist environment. You want it to be wet to dry. This will actually help with the debridement process of necrotic tissue. So let's say you have the ball of the foot, you've put the wet to dry dressings on every day, you take it off, and as you're taking it off, it will actually take off the dead tissue. And the reason why is because the reason why you want to do this is because it keeps the wound nice and clean. And the more tissue you take off that's dead, the more the good tissue will actually start to heal around it. If there's dead tissue left there, new tissue and good tissue just won't necessarily be able to work with that very well. Another thing we actually do is elimination of the pressure, so don't walk on it. Patients who are diabetics that have been diabetics for a long time with neuropathy will tend to be able to overcome things. I know that neuropathy is the numbness and the tingling and the pain, but it's a different kind of hard. It's just hard to explain how the neuropathy pain works, but the numbness tingling tends to work in their advantage in the sense they're able to walk without having severe pain, but the numbness allows them to walk and not realize that they're walking on ulcers, or that they're applying pressure to areas that are breaking down that will actually become worse. So you want to use certain types of shoes, have them use walkers or canes or crutches, whatever you can do to actually kind of get them off that pressure point. Because like I said, once that pressure breaks down, then you just now have an ulcer, and it snowballs into other problems and issues. All right, so for managing pain, for neuropathy, neuropathic pain. Symptoms of neuropathy are burning, muscle cramps, piercing, stabbing, darting pain. The metatarsalgia, you have the hyperalgia, and then you have allodynia. You also have the numbness and tingling. So medication that can help this is Lyrica and Cymbalta. I don't think this is on your list of meds to learn. And you don't have to learn them, but just be aware of it. Lyrica, it helps definitely with nerve pain. And recently, I've had a lot of doctors actually prescribe it for shingles because that is a nerve-related diagnosis, and Lyrica being a nerve-related medication, it tends to help. So keep that in mind if you actually start taking care of patients with Lyrica, that they've got some sort of nerve pain somewhere, and that most likely it's because of their diabetes. But these are the symptoms of neuropathy. But like I said, I think for the most part, I think the burning and the numbness, tingling, and the pain is really what I see more often than anything else. All right, so remember, you have patient safety because of risk for falls, you have risk for an injury, and you have slow wound healing. And this is all going to increase their blood sugar. So this is actually a vicious cycle. And it's just one that you just have to kind of control and just keep going around and around until something else happens. But again, I think that what I've done, as I've spoken for the last hour, you can't give enough information, you can't give enough education. Teach your patients on a level that they can actually understand it. But remember, this is a continuous cycle. Blood sugar needs to be controlled, and if it's not controlled, then it's going to give you hyperglycemia. Hyperglycemia is too much blood sugar, and your blood is too thick. Extremities are more extremities tend to be more affected by that because it will cause wounds and skin breakdown, which causes infection. Infection and wound breakdowns cause your blood sugars to go higher. So again, it's really just a cycle that goes over and over and over and over again. So it's not one that's ever going to stop. It's like I said, you just try to manage it as much as you possibly can. All right, so other issues with diabetes, you have reduced vision or diabetic retinopathy. Causes could be poor blood sugar or poor blood glucose control. You have proteinuria, you have diastolic hypertension, and you have long duration of diabetes. So again, I mentioned this before, capillaries in your eyes are very microscopic, and if your blood's too thick, then you tend to get less circulation, less the ability to function correctly, and you will develop diabetic retinopathy. So this will really cause blindness. So what do? You'll visit the optometrist for a functional vision assessment, and you'll get appropriate eyewear and visual aids. As I was reading the chapter and found this part of the diabetic retinopathy, it really just kind of dawned on me that patients who can't see very well will compensate for the best that they can in their ability. They try to keep their independence as much as they possibly can, which is great. I mean, you want to promote the independence, teach them what they can do to, prevent the falls and the injuries and the problems that they can have. And like I said, they'll do what they can. But then it kind of, like I said, it dawned on me. I was like, well, if they're not able to see real well, how do they actually drop their insulin? For those of you who actually have done your clinicals, or the ones who have actually pulled up insulin in your block 1 rotation, those needles are very small. Those lines are very tiny. So, and those are for us who can visually see well. If you can't see very well, I mean, how do you drop your insulin? How do you give yourself your injections? And how do you actually read a glucometer? And if they can't do these things, then and they want to keep their independence, they just tend to do what they can, and that may not be the best option or the best choice or the best way to go through things. So keep that in mind that, when you take care of these patients that have diabetes, we're too quick to judge and to react to their non-compliance and why they didn't do what they were supposed to do, or why they didn't do what they could have done to prevent wounds and their neuropathy and their kidneys and all this other stuff. But kind kind of see where they're coming from and find out if there is an issue. Whether or not, I told you guys I did my master's in health literacy, and you'd be surprised at how much we, as educated people, talk as if we're talking to educated people, and we're really not. So keep things as basic as possible. Try to keep it so they can understand it, and find out if they really either one can understand it, or if they really want to hear what you have to say, and try to give them whatever you can. I mean, something's better than nothing, but I have a little soapbox on diabetic patients, and you do what you can to get them where they need to be, but not everybody can actually get there. So kind of keep that in mind. So teaching for self-management. I just said all this stuff. You're going to assess their learning needs and their readiness to learn. You're going to assess their physical, cognitive, and emotional limitations. Patients, especially kids with type 1 diabetes, you're 6 years old and now you no longer can eat, the snacks in the afternoons, or you have to really watch what snacks you can have. If you're, I was a latchkey kid growing up, and we'd come home. My sister and I would sit in front of the TV and watch cartoons and eat, peanut butter and crackers, and just sit there until my mom came home. And if someone at that point would have said, "Hey, you're diabetic and you can no longer do these things," it's really a shift in lifestyle, whether it be for kids or adults, and emotionally that's got to be really tough. So you have to be able to not only take care of them physically, but just really kind of take care of them emotionally, and try to give them as much information as you can to try to get them to understand what to expect in the future. The survival skill information that's in your book, in-depth education. Again, if they're at the very beginning, don't talk to them with a degree in diabetes when they have no idea what you're talking about. So again, find out what their limitations are, find out what they're able to learn and what they're willing to learn, and start there. If you do have somebody who does very well and probably could teach you about diabetes, then at that point it's more of an in-depth educational process at that point. The psychological preparation. Again, if you came to me tomorrow and said I was diabetic, I'd die. I mean, I love my Reese cups, and I love my ice cream before I go to bed, and I'm always drinking a Pepsi and a half a pound of sugar in my coffee. So psychologically, it would just kill me. So but I think I'd probably learn to work out a little bit more so I can burn off as much of that sugar as I possibly can, and kind of go from there. So as I speak, I actually thought about another process too. Two things. One, you actually have a patient who's diabetic that will believe in the concept of, I will eat an entire cake and I'll just take insulin to offset that. In theory, that sounds pretty good, but in real world, that really doesn't work. So kind of keep that in mind. And the other process is on the flip side, which sounds very contradictory, but those of you who've heard me before, I'm very logical, and I want patients to do what they can within their scope of living. If you have a patient who is end-stage renal disease, that is a severe diabetic with half their toes cut off on one foot and their leg cut off on the other side, eating a whole cake and try to offset it with insulin, I don't find that to be a big deal. What else do they have to lose? The reason why I bring this up is because, again, I want you to really, the whole point of this entire PowerPoint is not to just teach you about diabetes and type 1 and type 2, and what to do, what to look out for, and interventions. It's really to teach you guys that you're going to go into a profession where you're going to see a lot of diabetes. You're going to see a lot of symptoms. You're going to see a lot of ranges of people from, very well educated and knowing about their diabetes to someone who just found out yesterday that they have it. And you're going to battle these things every day and try to come up with ways, and you're going to be very creative on how to get these people to understand their disease process, what they need to do, what they should do, and what they can do. So kind of take something away from that. So again, for outcomes, after all this information and education, what to expect. Our goal after all of this is for your patients to achieve a glucose control. So again, our target's 100. It's 140 to 180 for surgical, and for severely ill, you want 200. Avoid acute and chronic complications related to the diabetes. You want to try to slow, they're going to get neuropathy, they're going to get diabetic retinopathy, they're going to get these things no matter what. But if you can control the blood sugars and teach them how to live as healthy as possible, you can at least slow down the progression of these diseases. Have a complete recovery from procedures without complications. In euphoria in general, I know that if you have a patient that comes in and has surgery and blood glucose that are fairly high, you control this stuff, then yes, in that euphoric world, you would love for them to recover and heal and just be discharged. But and that could happen. I don't want to sound like a Debbie Downer, but I think that in real world, keep in mind that a lot of these things come from complications from diabetes. Control their pain with whether it be Lyrica or long-term acting pain medications. You want to slow down the progression of the retinopathy, give them optimal vision. You want to have good urine output. We don't talk too much about this module with kidneys, but I told you guys from day one, especially in block, I think it might have been block one, that your kidneys for me is really just the ultimate organ that really controls the rest of the body. And I think as you go through block 2 and 3 and 4, you'll find that your kidneys play a big part in disease processes and how it really helps your body maintain homeostasis, and it does what it can to keep you alive. Your output is a big part of that. Good mental health. Again, you've been diagnosed with a long-term disease, and you can do what you can to control it and have some sort of good outlook on and be positive about what it can. And that's possible. I really do think that that's. I have friends who are diabetics and they live very happy, healthy lives, and they do what they can. They know what they need to do. And then you also the outcome of less hypoglycemia, the yo-yo of, one day you're too low, the next day you're too high. That takes a really big toll on your kidneys and your body. So your outcome for that is, like I said, in the perfect world is to be 100, but at least keep it 90 to 120, not the 70 to 200s. So. All right, so I think we're getting close to the end. The one thing I wanted to bring up was the dawn phenomenon, which I think was very interesting. All people have it, diabetics or not. It's a surge of hormones every morning between 4 and 5. Diabetics do not have normal insulin responses to adjust for this, so it actually makes their blood sugar increase. Ours does the same thing, but our pancreas helps kind of adjust to those hormones and actually brings your blood sugar back to a normal level. Things to do to actually help with this for your diabetics is to eat a dinner earlier in the evening and do something active after dinner. So that way, if you tend to get yourself on the slight lower side, whether it be 90 or 80, at least at 4 in the morning, it spikes your blood sugar a little bit higher, but at least you have that room to play with it. So I find that very interesting. I think this might be the last slide. So sick day guidelines. You're going to have patients who are going to be at home. They're walkie-talkie as alert-oriented, self-sufficient people who just control their blood sugar as best as they possibly can. And they're all going to be just like the rest of us, get the cold, the flu, and the strep, and nausea and vomiting, diarrhea, and all the other stuff. So with that, when you're sick, you just don't want to do anything but lay on the couch or sleep all day long. And for most of us, that works. But for diabetics, that doesn't work. So there are sick day guidelines. So for a diabetic patient, to have them try to eat and drink plenty of fluids, at least 50 grams every 3 to 4 hours. Whether it's broth, juice, whether it be applesauce or crackers or Jello, get something in you so that way you at least have the energy to just sustain life. Also, because we know you have infection, that also increases your blood sugar. So you don't want to sleep for 8 hours at a time and find out that, 8 hours later at 3 in the afternoon, your blood sugar is 300, because that doesn't work. So they have to be able to check their blood sugar every 3 to 4 hours just to make sure that they're at least within a normal range. If they creep up to the 120s and the 150s and the 200s, then continue taking your insulin, even if you are not eating and you don't feel well. Because you need to at least control as much as possible. Now, they'll do fairly well, and they'll probably get over the illness, but if If it turns out to be too much for them, your patient will stay at home until they possibly can't stay home anymore, but they're going to try to control their sugar until they just can't, and then they'll come to the hospital. You want them to do daily weights. You want to check their temperature, their breathing rate, and their pulse, because these may be signs of DKA. DKA, we already know, it's blood sugar higher than 300. Once they get to that point, the diabetic ketoacidosis is taking over control. They will have signs of abdominal pain, vomiting, rapid breathing. The more fluids they lose, the more dehydrated they become. That makes their urine dark. They get the dry mouth, the fruity breath, the drowsiness, because now at this point they just got too much sugar, not enough fluid, and at this point they just need to get help. Have them call their doctor. When their blood sugars get a little too high, because it just snowballs into the DKA, and at that point no one can help them except for an insulin drip and us. So definitely teach them about these sick days. Not going to want to do it. They're going to want to sleep all day and all night, and wake up with blood sugar sky high or too low. But they definitely need to kind of check it and try to keep it as balanced as possible. And that's the end of the slide. So 1 hour and 10 minutes wasn't too bad. I know it's a lot of information. Again, when you read your chapters, when you keep listening to this over and over, just keep in mind it's all about the education. It's all about learning the signs and symptoms, what to do, what your outcome expectations are, and all of that really is transpired into education for the patient, because whatever you know, they need to know, so that way they can take care of themselves as much as possible. So if you have any questions, let me know, and I will see you guys in class. Thank you.